National Malaria Eradication Program, National Diarrheal Diseases Control Program and National TB Control Program. Introduction. Since India has become free, several measures have been undertaken by the national government to improve the health of the people. Prominent among these measures are the national health programs which have been launched by the central government for the control and eradication of communicable diseases, improvement of environmental sanitation, raising the standard of nutrition, control of population and improving rural health. Various international agencies like WHO, UNICEF, UNFPA, World Bank as well as number of foreign agencies like SIDA, NIDA, NORAD and USAID have been providing technical and material assistance in the implementation of these programs. So now we have how to achieve national health programs. By improving host resistance to environmental hazard. Next, by improving environmental safety. Next, by improving health system design to increase the likelihood, efficiency and effectiveness of the first two goals. So now we have objectives of national health programs. We have to know about the national health programs, that is NHP in India. Next, we have understand the relevance of the NHP. Next, we have understand difference between vertical and horizontal programs. After this, we have why national health programs. For this, we have disease burden is high. Next, geographical spread. Next, proven strategy for prevention and control are available. Next, we have adequate infrastructure is in place. Next, resources for program implementation are available. Now we have prevention of infectious disease transmission in sports. A variety of infectious diseases can be transmitted during competitive sports. Mode of transmission in athletic setting include person-to-person contact, common source exposure and airborne or droplet spread. This paper reviews the most commonly reported infectious diseases among athletes and discusses the potential for transmission of bloodborne diseases in sports. Guidelines are provided regarding measures to prevent transmission of infectious diseases in athletic settings, including hygienic and infection control practices, vaccination and education of officials, coaches, trainers and sports participants. An understanding of the most prevalent diseases and associated risk factors is crucial to conceptualize the role of the sports in health prevention and promotion. In developing countries, sports is widely used as a tool to educate individuals and communities on the risk factor associated with HIV and AIDS. In spite of the fact that HIV and AIDS and other communicable diseases continue to affect millions of people around the world, there is a significant increase in the global burden of non-communicable diseases related to lifestyle changes in physical inactivity, unhealthy diet and tobacco use. Now we have communicable diseases. Communicable diseases are also known as infectious diseases or transmissible diseases, are illnesses that result from the infection, presence and growth of pathogenic that is capable of causing disease, biologic agent in an individual human or other animal host. Following are some examples of communicable or infectious diseases. We have hepatitis, polio, influenza, HIV and AIDS, leprosy, malaria, diarrhea, tuberculosis, etc. These diseases caused by viruses, bacteria, fungi and parasites are capable of spreading among people through the air, blood and other bodily fluids. In this topic, we are discussing about the National Malaria Control Program, that is NMCP Diarrheal Diseases Control Program and National TB Control Program. So now we have National Malaria Control Program. A national malaria eradication effort was originally proposed by Louis Level Williams. The NMEP was directed by the Federal Communicable Diseases Center, now the Center for Disease Control and Prevention or CDC, created in 1946 and based in Atlanta, Georgia. It was a cooperative undertaking by federal, state and local health agencies. The program had evolved from the Office of Malaria Control in War Areas, which has been created in 1942 to suppress malaria near military bases in the United States during World War II. The CDC's first director, Justin M. Andrew, was also Georgia's chief malariologist. In 1947, at India's independence, 22% population of country was estimated to suffer malaria with 75 million cases and 0.8 million deaths due to malaria annually. To combat devastating effects of malaria, the National Malaria Control Program was launched in 1953, built around three key activities: insecticidal residual spray, that is IRS with DDT, next monitoring and surveillance of cases, and next treatment of patients. Malaria-related morbidity and mortality in India rapidly brought down within a few years. Encouraged by the program's success, it was converted to National Malaria Eradication Program, so-called NMEP, in 1958. But in 1976, there was a massive resurgence of malaria with 6.46 million cases reported, attributed to poor health infrastructure and suboptimal monitoring and logistics in many parts of the country. A major international effort along the line of the NMEP, the Global Malaria Eradication Program, that is 1955 to 1969, administered by the World Health Organization, was unsuccessful. Now we have symptoms of malaria. Typically, malaria produces fever, headache, vomiting and other flu-like symptoms. The parasite insects and destroy red blood cells, resulting in easy fatigue, ability to anemia, first convulsion and loss of consciousness. Parasites are carried by blood to the brain and to the other vital organs. Malaria in pregnancy poses a substantial risk to the mother and the fetus and the newborn infant. Pregnant women are less capable of coping with and clearing malaria infection, adversely affecting the unborn fetus. So now we have treatment of malaria. Malaria is an entirely preventable and treatable disease. The primary objective of treatment is to ensure a rapid and complete elimination of the Plasmodium parasite from the patient's blood in order to prevent progression of uncomplicated malaria to severe disease or death and to chronic infection that leads to malaria-related anemia. From a public health perspective, treatment is meant to reduce transmission of infection to other by reducing the infectious reservoir and by preventing the emergence and spread of resistance to antimalarial medicines. So now we have National Diarrheal Diseases Control Program. Objective and activities of the Diarrheal Disease Control Program, launched by WHO in 1978, are described. The program aims to reduce the mortality and malnutrition due to the diarrhea, and by making available oral rehydration salt and training in the treatment and prevention of diarrheal diseases. Research on the causes, prevention and treatment of diarrheal diseases is also being organized with the collaboration of national and international agencies. National Diarrheal Disease Control Program, so-called NDDCP, was launched in 1981. The main objective was the reduction of mortality through introduction of ORT. Goals were reduce diarrheal associated mortality in children less than 5 years by 30% by 1995 and by 70% by 2000 AD, reducing CFR to less than 1% improvement in water and sanitation facility was the long-term goal of NDDCP. Diarrhea, also spelled diarrhea, is the condition of having at least 3 loose or liquid bowel movement each day. It often lasts for a few days and can result in dehydration due to fluid loss. According to World Health Organization, diarrhea is defined as passage of unusually loose or watery stool, usually at least 3 times in a 24 hours period. However, it is the consistency of the stool rather than the number that is more important. Passage of even one large watery stool in young child is diarrhea. Frequent passage of normal stool is no diarrhea. Now we have sign and symptom. Sign and symptom includes loose watery stool, abdominal cramp, abdominal pain, fever, blood in the stool, bloating, nausea, urgent need to have a bowel movement. So now we have treatment of diarrhea. The rational treatment of diarrhea consists in the prevention of dehydration by oral rehydration therapy, so-called ORS. Breastfeeding should be continued in dysentery. Cotrimazole is given in addition to ORS. If the response is unsatisfactory, nalidixic acid is given for 5 days. Any program for diarrheal disease control must include provision of potable water. So now we have National TB Control Program. The revised National TB Control Program, so-called RNTCP, based on the internationally recommended directly observed treatment short course, so-called DOTS strategy, was launched in 1997, expanded across the country in a phased manner with support from World Bank and other development partners. Full nationwide coverage was achieved in March 2006. In terms of treatment of patients, RNTCP has been recognized as the largest and the fastest expanding TB control program in the world. Under the program, diagnosis and treatment facilities are provided free of cost to all TB patients. For quality diagnosis, designated microscopy centers have been established for every 1 lakh population in general areas and for every 50,000 population in tribal, hilly and difficult areas. More than 13,000 microscopy centers have been established in the country. Free treatment services are available for TB at all government hospitals, community health centers, primary health centers. DOT centers have been established near the residence of patients to extent possible. All public health facilities, sub-centers, community volunteers, ASA and women's self-group, etc. also function as DOT providers or DOT centers. So now we have goals of the program. The goal of TB control program is to decrease mortality and morbidity due to TB and cut transmission of infection until TB cases to be a major public health problem in India. Objectives of the program. Objective of the programs are as follows: to reduce the incidence of the mortality due to TB. Next, we have to prevent further emergence of drug resistance and effectively manage drug-resistant TB cases, to improve outcomes among HIV-infected TB patients, to improve private sector on a scale commensurate with their dominant presence in healthcare services. Next, we have to further decentralize and align basic RNTCP management unit with NRHM block level unit within general health system for effective supervision and monitoring. Now we have risk factors of TB. Anyone can get TB, but people at high risk generally falls into two categories. Number one category, people recently infected with TB bacteria. Number two category, people with medical conditions that weaken the immune system. TB bacteria can live in the body without making the person sick. This is called latent TB infection. In most people who breathe in TB bacteria and become infected, the body is able to fight the bacteria to stop them from growing. People with latent TB infection do not feel sick, do not have any symptoms, and cannot spread TB bacteria to others. On the other hand, when the TB bacteria begins to multiply and the person suffers with tuberculosis, doctor call this TB as active TB. A person with active TB disease may have any or all of the following symptoms. Number 1, a persistent cough. Number 2, constant fatigue. Number 3, weight loss. Number 4, loss of appetite. Number 5, fever. Number 6, coughing up blood. Number 7, night sweats. Now we have prevention of transmission of infection. Those with pulmonary tuberculosis are contagious upon about 2 or 3 weeks. Once their treatment has begun, earlier these patients were isolated. These days, isolation is not practiced, but some precautions are important to prevent the spread. These include, number 1, isolation from workplaces, school and colleges and area with crowds. Number 2, covering one's mouth and nose while coughing or sneezing. Number 3, adequate and careful disposal of tissues, usually burning or disposal in sealed plastic bag is recommended. Number 3, sharing beds and rooms with uninfected persons while sleeping should be avoided. After this, we have conclusion. Recent outbreaks of infectious diseases in athletes in competitive sports have stimulated considerable interest. The environments in which these athletes compete, practice, receive therapy for injuries and travel both domestically and internationally provide varied opportunity for the transmission of infectious diseases. The purpose of this medical literature review is to identify the agent most commonly reported in the medical literature as responsible for infectious disease outbreaks in specific sports and their modes of transmission, and to guide targeted prevention efforts.